We have a very exciting guest today, Dr. I'm going to say her name incorrectly, but the last name I got right. Estevana Isaac, who's going to talk about what the process is for getting a neurologic event evaluation. Dr. Estevana Isaac. She is a clinical neurologist, and she is going to talk to us a little bit more about the process of getting an evaluation for a neurocognitive or neurodegenerative disease process. Next week, we are going to have a neurologist talk to us about vascular disorders. So for many of us on this call, it's really important to understand what goes into getting a diagnosis for Alzheimer's or related dementia, or maybe the pain or neuropathy that we have. And today, Dr. Isaacs is going to talk to us about that. Dr. Isaac, the floor is yours.
Thank you. I'm so excited to be here, and thank you for having me. So like Dr. Parker said, I'm going to be talking to you about the diagnosis of neurodegenerative diseases. And I agree, that does sound like a mouthful, but I promise I will do my best to break it down and simplify it as easy as possible. So first, I'm going to share my slides. Let's see. Let's see. All right, so here we go. So like you said, so this is the clinical diagnosis of neurodegenerative diseases. I am assistant professor of neurology within the division of behavioral neurology and neuropsychiatry. So what are neurodegenerative diseases? So really, it's a wide range of chronic conditions that are characterized by progressive neuronal death. So the brain cells over time are injured and they die. For the most part, the neurodegenerative diseases that I'll be talking about today are the ones that occur in your brain cells. So Alzheimer's disease is considered a neurodegenerative disease because of the fact that amyloid protein and phosphorylated tau protein are misfolded protein that aggregate in the brain, injure the brain cells. And that's why over time and gradually, you start to see that when you look at imaging, certain regions in the brain look smaller than what they should be as you age, right? One of the great things is that the exercises that are encouraged in this BrainTalk Live and the physical exercise, cognitive stimulation, social engagement, all those different things are actually very protective over time so that you decrease your risk. And now there's more talk about diet and your environment, all those different things decrease your risk for that even happening or your brain cells getting small or injured over time. So all these things to prevent neurodegenerative disease are just as important. But this talk in particular, I'm going to be talking about things you can do to make sure that you detect it early, or make sure the clinician that you see detects it early, and things that we do to detect it early to make sure that if there is a diagnosis, we can manage it and make sure that your quality of life after that diagnosis is sustained, right? So Alzheimer's disease is the most common, but there are other types of neurodegenerative diseases caused by different proteins than amyloid protein and tau protein. So for example, Lewy body dementia, sorry, I'm in New York, so you're gonna hear some sirens. But Lewy body dementia, frontal temporal dementia, all those different types of diseases have different protein that are driving the clinical presentations, and they can look different than Alzheimer's disease. I will briefly go over some less common neurodegenerative diseases as well. So as I discussed, when you see your clinician, let's say that you or a family member is concerned about memory or areas of thinking, and you just want to get it checked. You want to know whether or not it's something you should be concerned about. what they'll do is they'll do a clinical history, they'll do an exam, and that will be focused on the neurological exam in particular, and included in that are screening tests. So like there are tests called the MOCA or the MMSE that the clinician will typically use to detect whether or not we can pick up some of the concerns from your history on the testing itself. After that, if we're talking about a very mild case of memory impairment or thinking problems that we're having a hard time picking up even on the screening test, you can see a neuropsychologist, which is a different provider, but they will spend hours with you kind of going through the different types of testing to really pin down what area of thinking is most impacted. And that's always helpful as ancillary support when we're looking at other supportive tests and making the diagnosis. So another big part of the diagnostic process is also brain imaging. We have to look at your brain to see what areas are affected. Is it consistent with the clinical history that you're providing, the exam that we did? And then there are other supportive tests we can do based on the other diagnoses that we're considering, right? So let's say we're considering Alzheimer's, but maybe, Lewy body dementia could be a possibility too. There are more tests that we can choose from to make that diagnosis. More recently, biomarkers are now being incorporated into the clinical diagnostic process, which has been a great move because sometimes just based on the environment, your lifestyle, related factors, all those different things that make you unique, your clinical presentation is not going to be the same as the next person. So the more that we're precise in our diagnoses, the better. And I'll
Excuse
go
me, Dr. Isaac, can
Mhm.
you tell them what a biomarker is, please?
Of course. So biomarkers take that next step. So basically, I describes how when you think about neurodegenerative diseases, it's a protein that is driving some of the injury that we're seeing to the brain over time. A biomarker can look at different mediums within the body to determine which protein is driving the clinical presentation that we're seeing, right? So for example, Alzheimer's disease, one of the hypotheses is that amyloid protein is the big driver, right? There's also phosphorylated tau protein as a driver too. So we have different ways in which we can look at different things in your body. So for example, I'll move forward and I'll talk about okay, actually, yeah, I'll move forward and I'll just skip to this part, right? So for example, Alzheimer's disease. You have fluid that circulates around your brain and around your spinal cord, right? And that fluid can basically tell us whether or not you have amyloid protein in the brain or phosphorylated tau protein in the brain. And really, what happens is it's called a lumbar puncture is the procedure, but really it's we can access the fluid that's circulating around the brain from below the lower part of your back, right? And based on the levels of each of those different kind of aspects in your fluid, so for example, if amyloid protein builds up and it's a plaque in the brain, because of that buildup in the brain, you tend to have lower levels in what we call CSF fluid, and that's the fluid that's circulating around the brain. And for phosphorylated tau, once your brain cells are injured by the phosphorylated tau, you have, or injured in general, you have higher levels of phosphorylated tau in your CSF fluid. So just by looking at those different ratios, we can determine whether or not you have levels that are abnormal. I will tell you that these proteins, some of these proteins, most of these proteins naturally occur in the body. However, what makes it injurious, or what makes it injure the brain is the fact that it's folding improperly. So that's basically how we're detecting biomarkers, right? So that is an extra step. Before, in the past, what we would do is after a patient, so we would look at the clinical history, and then after a patient passed away, you can biopsy their brain, and then you can say, oh yes, I can see that there's amyloid protein, there's phosphorylated tau protein, and that was driving their clinical syndrome. And maybe you're right, maybe you're wrong. And that's how you made the diagnosis. Now we're moving an extra step forward and saying we're trying to make these diagnoses when people are still living. So that's the utility in biomarkers, right? And there's different ways in which you can detect biomarkers. So for Alzheimer's disease, it's not just CSF fluid. We can also look at amyloid PET scans. So this is an example of an amyloid PET scan. On this side here, it's normal, and on this side here, it's positive. I don't know if you can see my mouse, but we're kind of looking down on the brain, and then we're looking at different levels while we look down on the brain, right? And so the fact that we can see all the different grooves in the brain makes it negative, right? But once we see that it looks smooth on that brain, that's basically what that means that there's amyloid plaque building up, and that's consistent with Alzheimer's disease. And another way in which you can look at the same thing with a positive and negative amyloid scan is down here. This is a negative amyloid, this is a positive, and you can see the brighter and more yellow and red it is, that's a positive amyloid scan, and the darker and blue it is, that's a negative amyloid PET scan, right? And so there's controversy with kind of just looking at it visually, because sometimes people may say it's positive versus negative, and there's not always a consensus when they're somewhere in the intermediate section. So they are trying to move towards a way in which we can make it more numeric when we look at amyloid PET scans. Yeah. So so I talked about the fluid that circulates the brain. I talked about the amyloid PET scan. But really, the big move is that they're trying to make it so that you can detect Alzheimer's disease in your blood, right? And this is really important because the biggest things I hear from my patients is, I don't know if I want to do a lumbar puncture, which is fair. I've done lumbar punctures. I've seen lumbar punctures. I know they're not a very invasive procedure, but everyone has their own comfort level. And some people just feel more comfortable with just getting blood, for example. And then some people have other reasons why they can't get a lumbar puncture, right? So the fact that they're moving towards the direction of blood biomarkers is also great, because now it could just be a matter of getting it in your routine blood work, right? And a lot of these tests have been compared to CSF fluid to see whether or not they're just as reliable as CSF fluid, and it's been promising results. Same thing, they compare it to the amyloid PET scan, and it's shown some promising results too. So that's kind of the direction in which things are going. Now, let's say that you meet someone and they're having memory loss and their clinical picture looks very much like Alzheimer's disease, but you do the biomarkers and they're negative, right? And that tends to be kind of confusing, because the clinical presentation is one of the most important things that we rely on outside of supportive tests. So in those cases, there are other types of proteins that, like I said, can drive memory loss and difficulty with function. And late is one of those diagnoses that mimics Alzheimer's disease, but it's due to a different protein than amyloid protein or tau protein. It's due to a protein called TDP-43, and it's usually in older adults, 85 years old, and it usually stays within memory loss, and you don't always see it affect other areas of thinking. But when it occurs with Alzheimer's disease, which is a possibility, you can see it affect other areas of thinking too. So on from there, now I'm going to stop talking about Alzheimer's disease. I'm going to stop talking about late, and I'm going to go on to other types of proteins that can lead to difficulty with thinking, difficulty with function. And the second most common neurodegenerative disease from Alzheimer's disease is a Lewy body dementia. And that's due to alpha-synuclein protein. And you can have two different ways in which Lewy body dementia presents clinically. You can have a dementia with Lewy body, and you can have a Parkinson's disease dementia. And so a Parkinson's disease dementia is primarily when you have a predominant movement disorder or difficulties with your motor, and it's traditional what you think of with Parkinson's disease, and later in the disease course, you start to have more cognitive and functional difficulties, right? I'm going to talk less about that clinical presentation and focus more on dementia with Lewy bodies, because that is the presentation that is more consistent with impacting your cognition and areas of thinking. And so that's where I'm going to focus on when I talk about Lewy body dementia. And dementia with Lewy body can present with different features. We have core clinical criteria that we look for before we make a diagnosis of Lewy body dementia. So REM sleep behavioral disorder, which is basically you're acting out your dreams or you're moving in your sleep during a period in your sleep when you should not have any movement at all, right? And people usually go through sleep studies to make this diagnosis, or we can make it clinically as well, right? Other features are Parkinsonism. So you don't necessarily have to have Parkinson's disease, and it doesn't even need to be present, but it is something that can present itself as well. Visual hallucinations. So it's very common for patients with Lewy body dementia to see things that are not there. Some patients are aware of it, that they are not, that they are hallucinations, and some patients have difficulty distinguishing whether or not they are hallucinations or real. And then the last core clinical criteria is cognitive fluctuations. The name itself is a little bit misleading, but when you see it, it's more of like attention deficit. Well, not attention, I shouldn't say that, but it's almost can appear like staring spells. It can appear as if someone has lost consciousness for a period of time. It presents in very different ways. But when it happens, it can be very scary for families, and they are patients that tend to go to the hospital, get worked up for stroke and seizure and all those different things. And they don't necessarily have to be present, but when they are present and they're with other areas and with other clinical criteria, then it's more supportive of the diagnosis. Beyond that, there are more tests that we can do to support our clinical suspicion. But for the most part, when it comes to Lewy body dementia, we rely on the clinical criteria probably more heavily. And then everything else just is there to support our diagnosis. Now, because of that, there is also a big move to incorporate biomarkers even in Lewy body dementia in our clinical diagnosis. So the more objective data we have when we have our suspicions is only going to help our diagnoses. So alpha-synuclein protein, which is the protein that we see in Lewy body dementia, can be detected in skin biopsies. It can be detected also in the same fluid that I talked about that circulates around the brain and the spinal cord. So it's really great that we're moving towards this direction where we can become more and more specific towards what type of protein is actually driving the presentation that we're seeing. So now I'm going to step away from Lewy body dementia, and I'm going to talk about another type of neurodegenerative disease, right? So this is now a different protein that can present clinically different than the other proteins that I just talked about. So this protein, this type of dementia is frontotemporal dementia, right? And it can be driven by either protein. So it can be driven by TDP-43 and it can be driven by tau. So I know you're hearing proteins that I've already mentioned before, but you can also think of it as in there's different forms in which these proteins can develop, right? There's different ways in which they can form themselves. And based on how they form themselves, we'll categorize them as one or the other. So in this case, these are proteins that we see in frontotemporal dementia and have a preference for being more towards the front and the side of the brain. So in this image here, I'm going to be talking about 3 different clinical presentations that a frontotemporal dementia can have. So a frontotemporal dementia can present with more behavioral symptoms, right? And that's going to have a preference for the front of the brain. So if we look at A and if we look at B, right? So once again, we're looking down on the brain and we're looking at the side of the brain, and they're circling basically the same area on the imaging. The front of the brain is where a lot of your behavior and your personality is. So when that protein starts to build up in the front of your brain, it starts injuring those brain cells. And as you can see on the imaging here, it looks smaller than what it should be. And then the other regions in the brain that can be affected and change your clinical presentation are what we see here in C and D. And these are the sides of the brain. And this is going to affect your language areas. And there's another way, so there's different ways in which language can be affected, but it's considered a primary progressive aphasia. So you can have difficulty getting words out, you can have difficulty not knowing what objects are, or you can have difficulty finding the right words to say, which is a little bit different than which is not really which is more commonly driven by Alzheimer's disease, right? So when it comes to language, if someone has word finding difficulty, they tend to say, well, this is commonly what you see in Alzheimer's disease. If someone's having difficulty getting words out, if someone's having difficulty not knowing the function of certain objects, that's something where we'll say, oh, this is usually driven by the protein that we see in frontotemporal dementia. That's why, for example, with Bruce Willis, when he's having difficulty getting words out, people are saying, oh, this is a frontotemporal dementia. Same thing, in that case. Yeah. So just briefly, I'll touch base on less common neurodegenerative diseases, just so you're aware. So these are different proteins once again, and even with each of these clinical presentations, you can have different forms in which the protein, forms itself. And so you have different clinical presentations. It affects different areas in the brain. So we have cortical basal degeneration, PSP, CTE, heart, right? You don't need to know all these, but just being aware that there's such a wide range in which all these different proteins, depending on where they are in the brain, which form of the protein is present, that can change your whole clinical presentation, right? So once again, the great thing is that research is actively trying to make biomarkers more accessible, even in this context. We do have tau PET scans, and they have already been used in Alzheimer's disease to detect the phosphorylated tau. But outside of Alzheimer's disease, there's some variation, and I think the main goal really is that we can find tracers that are good at distinguishing and detecting all these different types of neurodegenerative disease, even with this protein. So I will briefly run over this. When you think about fast dementia, when you think about dementias that occur over a year, we honestly think about CJD most often. There are many things that can lead to a fast-moving dementia, but highest on your differential is usually CJD. But we still check all the other ones.
What is CJD?
So it's Creutzfeldt-Jakob disease. And basically, it's also, it's called a prion protein. So the prion protein drives the clinical presentation that you'll see. And it can basically, from the start in which you have cognitive or behavioral symptoms to kind of the more severe stages of the disease process, that can occur within 1 to 2 years, right? So it is a very fatal progression. And the symptoms that people present with can be very distressing, both for the patients and the families. And it's a very unfortunate diagnosis to make. So when we do make the diagnosis, we once again rely on the MRI brain. We can do other tests like looking at the activity in the brain. And then once again, we do have biomarkers for CJD where we can typically also, once again, look at the fluid that circulates around the brain and the spinal cord. And we can look for usually a test we call RT-QuIC. There are other tests that we can look in that fluid too to support that diagnosis, but together that's how we make the diagnosis. Okay. So I say all this because I just want you to know how important it is that we continue to move towards this goal of precision medicine. Everyone is so unique, everyone is so different. And so the more objective data that we're able to have, the better we get at making early and accurate diagnoses. We prevent delays in diagnoses. A lot of times, once again, like I said, when you have different environmental and lifestyle related factors, different cultures, you have a wide range of presentations that are caused by, sometimes the same protein. Someone presenting with Alzheimer's disease from one culture can look different from another person presenting with Alzheimer's disease from another culture. So this is only going to help us get better in making sure that we're making a timely diagnosis and an accurate diagnosis. So yeah, so hopefully that will add more objective data in our clinical decision making. So for me in particularly, psychosis and neurocognitive disorders is important because they are associated with worse outcomes. As a clinician, it's very challenging to treat features of psychosis when it presents itself in dementia because of the fact that antipsychotics, for example, have modest efficacy. And even if you do prescribe the medication, you still have to work with families and caregivers on ways to redirect behaviors and stuff like that. And it's also something where you always have to discuss the increased vascular risk with families as well. So they're aware that, this is a medication that can help, but at the same time, we have to weigh the risk and benefit. So I do use it sparingly in cases where I feel like safety is at jeopardy. But I really want to take more time to just work with caregivers and do training for behavior management so I can help improve the quality of life for the caregivers and increase participation in clinical research so that we can have better ways in which we can make diagnoses, more accurate diagnoses, and also help with decreasing the cost utilization that we're seeing for a lot of caregivers within this realm. And, there's a wide one, so basically I went through all these different types of neurodegenerative disease just so you can know too why there's such a wide range in clinical presentations that we see. So psychosis and dementia can occur in Alzheimer's disease, Lewy body dementia, frontal temporal dementia, all these things, but yet our management is so limited. So that's why it's so important to me that we continue to move towards precision medicine and help improve outcomes for patients and families. So thank you. And I would love to take any questions if you have any.
Dr. Isaacs, thank you. That's a very fine presentation. You really did give a lot of clarity to some of the procedures. So when you talk about neuropsychiatric or behavioral problems. I can't remember the word, psychosis.
Mhm.
Um, an easier word for psychosis here, we're here in the South, we might say acting out, acting up. Can you tell people what that means? Being belligerent, just tell them what that means.
Yeah, so, well, first, so psychosis can take on a lot of different features. So the primary ones that we look at is hallucinations and delusions, which can be, which can present itself in different ways. Some people also include paranoia or disorganized thinking. I think you also have to think of it in the context of the diagnosis that you're making, right? For other behaviors in which you would still consider antipsychotics, though, in the diagnosis of dementia, includes, maybe some physical aggression would be a concern that you would have if the caregiver feels like their safety is in jeopardy, or if they're doing things in which they can't provide personal care and stuff like that. So that would include that. Now, when it comes to frontal temporal dementia, there are features that maybe you would consider as acting out, but maybe wouldn't fall in the category of psychosis, right? So some of those features would be if someone is making inappropriate comments, being socially inappropriate in general, maybe they tend to be rude or something like that. Or someone's impulsive, so they just do what they want to do without thinking about the context, the social context, all those different things. So those are behavioral symptoms that can occur that maybe aren't in the same category of psychosis, but can be considered for further medication management.
So, Dr. Isaac, there are some questions in the chat, I think, that are specific to you. But when you start talking about behaviors and things, Wendy Williams, you mentioned Bruce Williams,
Mhm.
Bruce Willis, but Wendy Williams has been
Right,
diagnosed with frontotemporal dementia.
right.
And there are many on this call who think, well, there's nothing wrong with her. She should be free.
Yeah.
So if you could kind of clarify some of that acting out stuff with the Wendy Williams stuff, that would be
Yeah, that
appreciated.
would, of course, that's no problem. So behavioral variant frontal temporal dementia, it's so challenging to experience both from the patient's perspective and the family's perspective, right? Um, so with behavioral variant frontal temporal dementia, usually it is the case that they do really good on cognitive testing sometimes, right? But they're meeting the clinical criteria for some of the behavioral changes that you see. And on top of that, when you look at their MRI brain, you can see that the front of their brain looks smaller than what is normal for someone that age, right? And so that's why, people see a complete change in personality. Things seem as though, and the way in which it impacts function is more on a behavioral level than it is that, maybe they can't do things. But over time, you will start to see other areas of thinking that are impacted. So maybe it starts with behavior, but it can also start to include language, right? Uh, so one way in which you can see that happen is, for example, Bruce Willis, right? He's started having a language problem first, right? So he had difficulty getting words out. That area is also in the front of your brain, but it's on the side. Wendy Williams started having behavioral symptoms first, right? That area is also in the front of your brain, but it's kind of like in the middle, right? As the disease progresses, it can involve more parts of the brain. So Wendy Williams can start having language problems, and Bruce Willis could start having behavior problems, right? So that's basically how the disease process works.
There are some questions about oxygen in the brain, diluting proteins, and I think that I want you to look at the questions. I don't feel like I'm competent to answer some of those, but
Uh,
the
me-
oxygen one, because I think a lot of people think that you can do something simple and make all of this go away.
Let
They're
me see.
misguided. But there's a question about oxygen and CPAP.
Oh, okay. Okay. Can intaking more oxygen into the head area, CPAP, help dilute the protein that is affecting the brain? Okay, so I think there's a lot of different things that maybe is being combined there, but I'll start with this. So a lot of times with sleep apnea, right? If you think about what sleep apnea is, so CPAP is the management that's used in sleep apnea most times, right? That's usually the context in which people hear about CPAP. So it does provide kind of pressure to help with that breathing. So it's assisted breathing while you're sleeping at, not assisted breathing, but it helps with getting oxygen um, to your body and the brain while you're sleeping, because with sleep apnea there are periods in which you stop breathing, right? um so that's why people use it at night, and we always encourage people who have sleep apnea to continue to use CPAP, because if you don't, that means that there are periods at night in which your brain is not getting good oxygenation, good it's not getting good oxygenation to the brain, right? And you don't want that to happen, because that can be one more reason why you're increasing your risk for dementia as you age. So if you have a diagnosis of CPAP, if you have a diagnosis of sleep apnea, use your CPAP, because that will help protect your brain from further injury and decrease your likelihood of getting dementia in the future. However, once the protein has started to injure the brain, we do not have anything right now that cures that process. So once the process starts to develop and you start getting injury to the brain from the abnormal protein that's built up, we have things which we recommend you do to slow down that process. But right now we don't have a cure. So one way in which you can improve kind of the blood flow to the brain is physical exercise. So making sure that you're getting your cardio, your aerobic exercise 30 to 40 minutes, at least 3 to 4 times a week. Let's say if you'd like to go out for a walk or something like that, walk at a pace where you feel like, you're feeling a little breathless, right? Because you want that heart rate variability. That's going to really help your brain. So when you're thinking about oxygenation and blood flow to the brain, I think physical exercise is going to be more important than using CPAP, unless you have sleep apnea. If you have sleep apnea, then I would tell you, yes, use your CPAP and physical exercise, 2 ways in which you can improve your blood flow and oxygenation to the brain.
There is a question about diet and eating late at night. I don't know that that affects the proteins at all. You've given a great job explaining these different proteins and biomarkers and precision medicine. But on that note, what is your area of research?
Yeah, so my area of research is really focused on psychosis in Alzheimer's disease and related dementias. So like I mentioned, psychosis can occur both in Alzheimer's disease and frontal temporal dementia, vascular dementia, all these different things, but it makes it challenging just for management itself. And so that is really what I focus on, ways in which we can work with the caregiver to decrease the 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 challenges that we see when someone presents with features of hallucinations and delusions or anything like that. From a clinical standpoint, any risks and stuff like that, improve the quality of life of the caregivers and the patients. As far as food and your diet and all those different things, there is a big boom in that research area as far as the connection between your gut health and your brain health, and making sure that you're eating a diet that's anti-inflammatory. I think it's all holistic, so it's not going to be one supplement you should take, one vitamin you should take. It's really a lifestyle diet change that you start before your diagnosis, right? So the big emphasis is always on the Mediterranean diet, which is true, but really you're thinking about the ingredients that are typically used in a Mediterranean diet. It doesn't necessarily have to be Mediterranean dishes. So like green leafy vegetables, whole grain, fish, avocado, berries, beans, all those different things, making sure that you're incorporating that into your diet holistically to prevent the onset of neurodegenerative disease, right? All those preventative recommendations are much hard. It's much harder to see the benefit if there is. Yeah, it's much harder to see the benefit once you have the diagnosis. The ideal is you want to prevent the onset.
Okay, is there any research that you're doing that any of our audience may participate in and assist you with?
So I think for me, really what I'm looking at is working with caregivers and patients who are already experiencing symptoms of psychosis and are finding challenges in managing those symptoms. My focus is really working with them to have a systematic plan that doesn't necessarily um, focus on one medication, but kind of working together with the caregiver and the patient to make sure that we decrease, for example, how many times they go to the hospital. We decrease adverse events related to safety and injury risk and all those different things. Make sure the caregiver is informed about what to expect based on the diagnosis that they have. So that's really my focus from a clinical standpoint, because I do see a lot of patients in a clinical setting, and I just want to make sure that we're considering all the different environmental and lifestyle factors that go into effective behavior management.
So is your study or the work that you're doing something that people in Georgia may participate in?
Not yet, but hopefully in the future. As I'm new to the area of research, and I'm hoping that I continue to expand and move on and include other populations within my research goals. Oh, I think you're muted, Dr. Parker.
There are a couple more questions you can look at. I think we have a couple more minutes, but I just want to say thank you so much for taking the time to talk to our audience. They're really engaged and they really loved your presentation if you look at any of the comments in the chat. But you've done a whole lot to explain the neurodegenerative process and the diagnostic process from a neurologist perspective. And thank you for emphasizing lifestyle change, exercise, diet.
Yeah.
And I'm going to let you answer those questions, and I think that will be it. But thank you so much, Dr. Isaac. We have webinars every week. You're welcome to come back if you have another chat that you want to give.
Thank you. I appreciate that. And thank you, everyone. I enjoyed chatting with you guys all, and feel free to reach out if you have any questions.
Miss Emily, do you have any contact information for her?